Actually, we only spent 5 minutes on this, so it's going to sound like Good evening. Thank you for the opportunity to come and visit with you. My name is Bob Brace, and I am the Chief Compliance Officer with UMC. And I have with me Debbie Dabbs, who is our Chief Privacy Officer, and Shauna Bachman, who is our Chief Project Analyst. We are here to talk about disclosures for HIPAA and privacy matters, disclosures to law enforcement. Y'all have an opportunity to interact with law enforcement on a regular basis. And recently we had a question come up, what can we say, when can we say it? And we had an issue where we've actually maybe disclosed a little more than we should have, and it ended up in the papers. And so we're here to kind of talk about it a little bit to give you an opportunity to hear from us what are the parameters and what is legal to do and what is not. And it is not always black and white, as you might imagine. You know, Congress, after all, wrote all this rules, so all those attorneys up there get paid by the word when they write these regulations. What should take 2 paragraphs typically take 500 pages to write. So as we go through this, please feel free to ask any questions that you might have or any scenarios that you come through or come across, because it truly doesn't necessarily apply equally to every and all situations. All right? So with that, I'm going to turn it over to Debbie. And again, thank you so much for allowing us to come to you.
Okay, I get to do this because Bob's a coward. You guys are really scary looking, and all you guys are late, so you have to sit in the front of the church. Because we are going to be preaching here. Basically what we've got are the HIPAA privacy rules, and they tell us what we can and cannot say to people about our patients, whether they be law enforcement or each other or anything else. So we also have the Texas medical privacy laws, and they pretty much follow HIPAA. Texas is a little bit stricter in some of the things, like HIPAA allows us 60 days to produce a copy of a medical record. Texas says you have 15. So we do have to follow Texas law in that instance. Okay. This is an example of what we would consider to be law enforcement. You have police officers, the DAs, and any other federal or state agency that's charged with enforcing laws. I'm not exactly sure who that would be, but I'm sure there are a bunch. So we can have subpoenas, we can have court orders, judicial orders to release records, etc. And those are the types of things that if we have to follow them. We do have policies and procedures in place, so if you guys ever get a subpoena for a record, we request that you'd send it to medical records and have them release the information rather than do it from your house or the ambulance house, not your personal house, rather than your department. Send it to medical records and have them do it, because there's a checklist we have to follow to make sure that all the steps have been completed. Patients have a right. We have to give them assurances that we've informed the patient that this subpoena's out there and they can object and all this other stuff. So we have to make sure all those are followed. We have to get the identity of the police officers. Just because they're wearing a uniform doesn't necessarily make them a police officer. So we have to know exactly who they are. We can do that by getting a card, by writing down their badge number and their name, so that we have at least an identity rather than Officer Jones. And that helps us because it gives us a specific person to go back to. And that's one of the requirements that we have to have. We have to know who we're releasing the information to. All right, these are the list of what you can and cannot disclose. Court order, grand jury subpoenas, things like that. Those are the ones that we have written documentation in our hand that would go to medical records or HIM, health information, so that they can respond to it. When you're out on the field, if you ever get one of those, take a picture of it, because I doubt that it would be happening right then and there. So what you're going to get is an oral request from an officer at the scene. And that's when you have to follow these guidelines, kind of understand what you can and can't release when speaking with the police officer. So gunshot wounds, rape victims, stabbings, victim of violent crime, those are required releases by law. We are supposed to report those. So we have to make that report. And we would have to inform the officer at the scene if we felt that something like that happened, if they questioned us, etc. Also, you want to make sure if there's a death involved, You can give them information about that. We'll cover a little bit more about what you can do. Also, if you get permission from the patient, you can release any and all information that the patient tells you can release. If the patient says no, because there are some rape victims that say no, you can't release any information. Regardless of what the officer says, you can't release information because a patient has the right to control their health information. There's a 3-part test that falls under what you can release and how you can release it. It's explained here. Can they get by with de-identified information? Does everybody know what de-identified means? You just don't release the name or any other identifier like a date of birth. You would, if they were a 32-year-old female, you would change the age to like 30 or 40, whatever they're closest to, something like that, because you don't want to give out specifics if you have to de-identify the information. They pretty much have to ask exactly what they want. They can't ask leading questions, so it's kind of like in court. If you've ever gone to court, you answer the question that's been asked to you, and that's it. You don't try to explain, you don't try to give out any other additional information. I fail that test every time because I always want to explain. So I always have to like put my hand over my mouth and pinch my lips together or something because I'm going to continue to talk. All right. A covered entity, which would be us, EMS, the hospital, etc. You would need to release the information based on what you think is going on. So if you have a suspect, a fugitive, a material witness, a missing person, and the information that can be released is over here on the other side. And it would help with, like a missing person, you would release the name, if they had any identifying marks, tattoos, any other special things that might help identify them, like red curly hair, green eyes, maybe they had 6 fingers, something like that, because it's a characteristic that person would have. All right, if it's a crime for a victim, this is when it gets to be a little bit dicey for us because we want to help out law enforcement. We've just picked up somebody who's been shot, who's been stabbed, and we want to give them as much information as possible because we think we're doing it in the best interest of the patient. But we still have to be careful about what we release. And it falls under this category. If the patient agrees to the disclosure, all bets are off, and you can release the information, any information that the police officer asks. If the patient cannot agree, you have the ability to use your professional judgment. In your professional judgment, if it's in the best interest of the patient to release that information, but you only want to release the information that is necessary for the officer to do his job to apprehend the culprit, the criminal in this case. So if a patient is shot, you could probably release where the patient was shot, where you found them, maybe some information about what the patient was doing, if they were in the park, they were walking their dog. But if it starts crossing over into they were smoking pot, they were shooting up drugs, that gets to be a little bit more complicated as far as a release to law enforcement because it starts crossing over into healthcare. And so you want to be really careful about something like that if you don't have the patient's permission to release that information. Yes, sir.
Number one question from law enforcement is this life-threatening or do you think they are going to die? How do you feel that question?
Yes or no? Because that's an important question for law enforcement because then they want to know if they're going after a murderer or not. So, and they're also asking your professional judgment, which you are allowed to give.
Well, you can, if you will. It talks about that you're able to discuss the injury. You can discuss the injury without making a definitive statement of whether or not the patient is at risk to die or not, because that's more of a medical judgment. You can simply say, as a result of this accident, they have crushing injuries or whatever. That's fine, but at that point, you need to stop. Because the next question might be, if it's a single car accident, do you think they were impaired? Right? If you've been asked that question, the minute you say yes or no, you're making a judgment that would put you into the PHI, which puts you at risk.
And if you're wrong, that puts you at greater risk. Because the police are going to go with that information based on what you said, and you may or may not have a drug alcohol test to prove what you're stating. And so that can get you in a lot of hot water when you're put up on the stand in a court case. So that's the other thing you want to be careful about. Okay, if you're reporting a crime away from the premises, which means it didn't happen at your station house or on the hospital property, these are the things that you can disclose to law enforcement. You want to let them know what you think has happened, nature and commission of the crime, whether it involves a shooting, a stabbing, something like that, and the location of where you think it might have happened. And if you know where the perpetrator might be, you can discuss that. Okay, violent crimes. These are the ones that we always want to try and do as much as we can to be as helpful as we can for law enforcement. Because we want to get these people off the streets, we want to protect other people, and this is where your helpfulness can get you in trouble. Because you want to be careful about what you say and what you release to the police, because if you cross the line, you violated HIPAA. One of the things that HIPAA has now done used to be that the organization was responsible for all of its employees. So the organization would have to pay the fine and be held liable for anything that its employees did. However, now the law has changed under high tech, and the employees are responsible for their own bad acts. So if you're caught violating policy or violating HIPAA, they can fine you as well. And medical malpractice insurance and other insurances of that nature do not cover fines. So it'll come out of your pocket. And the fines can be as much as $1.5 million. So it can be quite costly depending on whether or not they feel like you did it purposely with malice. Of course, those are going to be higher fines than if they thought it was just a curiosity thing. So,
and just so you know that if you have read some of the stories about the celebrities in California when they go to the hospital, and employees of the hospitals in which they have been admitted release that information to the tabloids or get paid for that information, those people are actually going to jail. So if you were to release information to a publication, the newspaper, the radio stations, or somebody else that is not obligated or required for you to disclose that information to, you can be held not only for fines, but also have the risk of jail.
right. So like when George Clooney fell off his motorcycle and broke his arm, there were all kinds of people that got fired and fined and everything else because there were all kinds of reports that were made. EMS made reports, spoke to the tabloids, got paid for it. So if George Clooney ever comes here, you guys have to call me.
We can't do that.
I work for you. Come on.
Can't release that information.
Do you need to know?
Yes, I do. All right. One of the things that we did want to hand out.
Yeah, it's on the packet.
Yeah. You guys should have this attachment. It actually belongs to our policy that speaks to what you can and can't release to law enforcement. It's a flow sheet that was put together by us and legal counsel, mostly legal counsel, but don't tell them I gave them credit. And it tells you what you can, pretty much tell them if you're looking for a suspect of a crime, then your list is pretty limited. You can do name if you know it, address, ABO, blood types, type of injury, any distinguishing marks, that kind of thing, but that's about it. If it's a victim of crime, you can release other information as long as law enforcement attests that they're not going to use this information for the victim, that they really are looking for somebody else, that they don't think this is the perpetrator of the crime. If they believe that it's the perpetrator of the crime, then you have to switch over to the other column, and that's the only information that you can release. And again, you want to be careful to limit the type of information that you release to law enforcement to be basically about the injuries and a little bit about the circumstances, but not going too far with the circumstances. And we don't want to make you feel like you're having your hands tied, but you really need to think before you start talking to the police and telling them everything you know, everything that the patient told you. If your patient is cognizant and can answer, then you can ask them. The police are going to ask me questions. Can I discuss everything that you have told me with the police officers? If they say yes, you're fine. Document that in your run sheet that you asked that question of the patient and they told you could discuss the information with law enforcement. I know one of the questions we've had previously is with rape victims. The rape victims don't want to talk to the cops by the time the cops get there. They've told everybody their story. And so when they start discussing with you, if you're asking questions and things like that, ask them if you can tell the police what they're telling you. And if they say yes, you're good. If they say no, you can't. And always document that you asked that question. If the patient calls the Office of Civil Rights, who enforces HIPAA, the Office of Civil Rights is always going to side with the patient. So it's our job to prove we followed our own policies and we followed HIPAA. And the only way we can do that is if you document it. And what's the #1 rule of healthcare? If it's not documented, you didn't do it. It has nothing to do with healthcare. Because the record's the only thing we've got. And if you don't write down what you did, then you didn't do it. So you have to write down that you asked that question, that they gave you permission. Do you guys have any questions for us? Yes?
On our reports, if somebody does give us some information, we just need to totally leave it out of our report too, if they
No.
haven't given us permission.
No, your report is part of our medical record.
I mean, if they tell you something that involves whatever happened to them,
No.
it's okay to put it in there?
Yes.
Okay.
Because that's our medical record, and if the cops want it, they can get a subpoena if they need it later. But we will need it. We need all the information we can get. The docs need to know if the patient states they were shooting up, because they need to know what in the world they were doing. If they're high, if they need to give them narco before they do something, before they give them something else. So it's important to know. Any other questions? If you guys have any, please give us a call. You can follow this policy. It actually states on the bottom what the policy number is. I do apologize because the policy is very long and wordy. This is much more concise and easier to read, in my opinion.
When it is documented, somebody is shooting up, that needs to be in quotations, patient said in quotations. Is that still the standard
Yes,
that legal would want?
yes. Yeah, because you're actually quoting what the patient told you, not what you observed. And if you don't put it in the quotation marks, then it's like you observed it. So you want to make sure you're doing that as well.
I have a question. Several years ago, I wrote a report on, because it was a victim of family violence. Yeah, this lady was beat up. She says by her husband. She happened to have a husband and a common law husband at the same time. So that's all I put in my report.
That's interesting. I like that.
Yeah, it's always like that. When I wrote the report, the police officers subpoenaed the report. Well, it didn't have a name. So word got back to me, the next time that happens, put the name of the perpetrator in your report. Well, I did that a few months later, and they got barbecued for doing that. So what do we do in those situations?
If the patient tells you that they did it and that's the name, you can put that in your report. I mean, it's the same deal. You're putting it in quotation marks. That's what the patient told you.
Okay.
And that, I mean, if they barbecue,
Well, it wasn't the law that
oh,
administration got.
yeah, and I mean, it's kind of one of those things. I think half the time we're damned if we do and damned if we don't.
Yeah.
So it just depends on who gets the report and what happens. But generally, if a patient tells you, you are allowed to put that in there. And if we get information, like, you guys probably remember this, the older ones do. We actually had, you remember the lady that got the knife stabbed right through the eye socket? Well, the next day in the newspaper, her x-ray was on the front page. I had a heart attack because I'm like, oh great, who do I get to fire now? And it turns out we released that to law enforcement, and law enforcement released it to the press. So it's kind of one of those deals, once it's out of our hands, we have no more control over it. And they're not, law enforcement's not a covered entity, so they're not bound by HIPAA. And so we didn't have, I mean, there was nothing we could do to protect that information. However, we had several employees that thought that that was a really cool x-ray, so they pulled it up on the PAC system and took pictures with their phones. Yeah, several of those employees were no longer working for us after that. But it's that type of stuff that if you see, you need to report to us and let us know so that we can figure out what happened and make sure that other people know that you're going to tell on them. That behavior is not appropriate for our hospital and for our employees. Yes?
What about questions that are asked to the patient in witness of LPD? Like if we have a patient that we're taking care of in a public setting and we're trying to identify information to take care of them, those questions are then heard and videotaped by LPD. Are those going to be considered breach if the patient is answering our questions but being witnessed by LPD with recording devices?
If I was you, I would make note of that in your record, that they're there and they're doing it, because yes, you will be held. I mean, if they make a report to the OCR or somebody makes a complaint that information was leaked to law enforcement that shouldn't have, we're going to have to investigate it to figure out what happened. If you don't document that law enforcement was there and recording the conversation, we don't know. It looks like you told law enforcement.
Now, one of the other things you could do is you can ask the patient and tell the patient that law enforcement is here. They're going to be listening in on our conversation, and as I treat you and assess you, they're also going to be videotaping. Is that okay with you? And if they say no, you can turn to the police officer and say that the patient has requested privacy at this moment during this, while I'm treating them.
Hey, Bob, on that same comment, if the patient is impaired and unable to really make a lawful response, and they say, sure, can they come back later and say, well, I was drunk, I wasn't responsible for agreeing to that?
You're not making an assessment on their impairment at that point. You may understand they are or know they are, but you're not really making an assessment or judgment, because the last thing you want to do is that police officer asks you, is this person impaired? If you say yes or no, you really are answering a PHI question, and so you don't want to do that. So what you do is you have to remember that the patient always controls their information, and they can say yes or no to it. Now, then it becomes a matter for the police officer to respect that request or not. And their judgment then is this important enough for me to record this or take notes? You know, we have the question, if they're in the trauma bay inside the EC, and you're there giving your report to the physician and to the nurses, and the police officer standing right there listening, is that a violation? Are you violating confidences? And the answer to that question is no. At that point, because of the care, you're delivering information to the people who actually need it to care for the patient. The physician at that point, they're the ones in charge of the room. They can ask the police officer to leave if they so choose.
And in answer to your question, yes, if the patient makes a complaint to the OCR, the Office of Civil Rights, yeah, you could be held in violation. However, if you document well, we will be able to figure out what happened and see that the police were there recording. The patient said yes. There was no, you didn't do a blood alcohol test. You couldn't determine that they were over the limit. That kind of thing. And we'll defend you as best we can. And generally, the OCR has been pretty reasonable when we've had to deal with them. So we just kind of go through the steps of what we have, we send them our documentation and move forward.
And actually, there is a law that's recently been in Texas that unless that victim is in custody, we can't disclose whether they're impaired or not. In fact, you can't even do a blood test on them to make that distinction unless they give consent for that blood test. So again, it goes back to, you don't have to make a decision whether or not they're impaired. You just have to accept that answer, yes or no, from them, and document what they said. Because you can always ask the question, do you fully understand what I'm asking you? And again, if they answer yes, then you have to go with it.
Any other questions?
How do you handle people with cell phones or videoing while you're trying to treat a patient? I mean,
You can ask
if you're
them
busy
not
with
to.
the patient, if you're busy with the patient, you don't know they're recording.
No, you don't. And you really can't control that. No one can.
But, I mean, you wouldn't know how to document your account at all.
Yeah.
Right. And it, generally in a situation like that, they're gonna know that it came from an outside source and not us.
What you have to do is maybe rely on the police then to kind of get those people back. I mean, just think of it in terms of this balloon accident that just occurred. There were a lot of witnesses to that, a lot of people rushing out to help the victims. There's very little video of that actually happening. And one of the things they did is that I read is that the first responders were out there were asking people, please give us time to care for these people, get to look at them and take care of them. Don't be taking pictures, you know. And so most of the people responded and you know, were respectful enough not to do so. But you can never fully protect them from that.
On several instances where I've dealt with what we would deem as a possibly impaired patient, potentially in LPD custody, and we're treating them in the back of the vehicle. Most of the time on those victims, or on those people, we start an IV, we draw blood to help with diagnostic processes at the hospital. Is it a correct statement to that patient if they freak out about you drawing blood to make the statement of this is not for LPD, this has nothing to do with what's going on with you, between you and law enforcement at this time, this is for diagnostic processes for your medical care?
Yes.
Is that a correct statement? Okay.
And that's because LPD, you know, we used to be, many years ago, I worked nights here and in the lab, and we used to be the site. They would always bring them in, and we would have to do the drug testing and blood alcohol and chain of custody and all the rest of that. And we're no longer doing that. LPD has their own lab, so that lab would provide the blood alcohol testing. That does not mean they cannot subpoena the record and get our results, but our results are purely for patient care. They're no longer legal results. So,
What about documenting in your report the patient has possible ETOH on breath? Is that something that we should or shouldn't do? Like, we know somebody is impaired, and you put in there in your report that I noticed that ETOH smell on possible. I never put definitive. I always put in my reports possible ETOH noted on patient's breath. Appropriate, not appropriate, should we do it, should we not do it?
from a medical standpoint, I say it's appropriate because the physician would need to know that. And it could be that they just had a glass of wine. It's not that they're intoxicated. It could be if they're like me, they spilled it all over themselves. Because I'm so ladylike. But yeah, I mean, you know, to me, that is your documentation of what you're seeing with your patient and your assessment of that patient. And the more information you give the physicians and the care team in the ER, the better they are able to treat that patient.
You just don't want to turn around and hand that and say, here, officer, would you please hold this while I take care of the patient?
Yeah.
Take care of the victim?
But you wouldn't relinquish that to the officer on scene.
Well, I know, but that, I'm just
saying that
you don't want to turn around and say, guess what? I smell alcohol on the victim's breath. You don't want to say that to them. Perfectly legal, perfectly appropriate to document it. You just don't want to communicate that in any way to the police officer.
Yeah, and if they really need it, they'll get it.
Yeah,
They'll
fine.
subpoena the medical record, which your run sheet will be part of, and they'll get that information.
We get asked that question a lot though on car wrecks, like officers.
Yep.
I smell alcohol. And we're supposed to say no.
My nose is broke.
Well, so what you say is, at this point, I'm not able to make that judgment.
Yeah. Because we don't want to tick off the police. I mean, you know, we want to be able to work with them, so we want to be as nice as we possibly can. And we want to have some sort of scripted answer that's politically correct as much as I need that. So you're just like, no, I can't tell you. Sorry.
Come over here.
So when does it become a point to where you're impeding their investigation?
It's not a matter of impeding their investigation, and if they so deem it, they have to come to you and explain to you and why it's necessary for you to deliver information. But even as such, all you can give is the demographic, name, date, birth, those kind of things.
If it's the suspect.
Yeah.
And if it's the victim,
You can't say anything.
well, you have a little bit
Well, I'm talking about PHI.
Yeah.
You're restricted to, in fact, it says in the rules, absolutely no PHI is to be discussed.
Unless
So,
the patient has given permission.
now, I know that's difficult when they're asking you questions, and you know these guys and they're your personal friends, or you know them for a long time, and they ask you a question, you want to help them, understand. But the unfortunate piece is you're not there to help the police officer, you're really there to help the victim, your patient, and you have to respect their rights.
A lot of time PD wants to jump in and talk to the patient. You just let, is that okay? It's open forum, they can ask whatever they want.
If the patient is cognizant
And agrees.
and agrees, absolutely.
Because you have to remember, if you're there, the patient's in your custody. You're the one that's directing the care. The physician's not there, you're out in the field, you're the one taking care of that patient. And if you let the cops come in and you have a bad outcome on that patient, guess whose butt is on the line? You know, you have to remember your license is on the line as well. So the patient has the right to agree to talk to the police or not agree. And if the patient says no, then you have to respect that and tell the officer that the patient is refusing to talk to him.
And when it's time to go to the hospital, it's time to tell the officer, we're leaving.
That's
You can
right.
ride with us, or we'll meet you there. It's time to go, and it's time to end that conversation.
That's right.
And I'll tell you, this is also one of those gray areas for you, and certainly one that's hard to delineate. But if you walk into EC and you see that police officer that is working for security for the EC, remember that you can't talk to them either. Now, they are there and they should know that that information on that patient is confidential. And they may get some information as a part of being in that room or vicinity, but you're not at liberty to discuss it with them either because they're not a part of the immediate care team. They don't have a need to know at that point.
And they're there to provide security. So if you feel that there's an outstanding threat, like to avert harm, if this is a gang shooting and they realize they didn't kill the person they were trying to kill and they're going to follow you to the hospital, then you have the ability to tell the cop, hey, we think we're being followed, this guy's still in danger. But that's pretty much it.
And I'll give you a hard example of that. About almost 20 years ago now, I was in an emergency room down there working. It was 2 a.m. in the morning. An ambulance rolls up, pulls out a gunshot victim, comes in, and there was a bunch of guys coming following them. Gang members. This was a gang shooting. The police officers who were there, just happened to be there, started asking questions of the paramedics, EMS teams. Well, where did you find them? And they were giving them, this is a gunshot victim. We found them in such and such a part of town, the general location. And do you know who shot them? No, we don't. But we think and we believe that the perpetrators may be coming here. And so they locked down the ER. 10 minutes later, the group of gang members that came with their friend went outside when they locked the ER down, and they had a encounter with the other gang, and they actually had 4 more people shot in the parking lot. So there may come a time where, just out of necessity, you may have to deliver more information than might otherwise be. In that case, the EMS said, well, we think there may be coming, and we need to prepare. So that was a little more than probably they could have said or would have said normally, but in this case, it was appropriate for them to do so.
Because it falls under that to avert serious harm or threat.
If our patient is in custody, LPD says we are arresting him for DWI, but we need to get his neck cleared because he's complaining of neck pain. Does he retain, or does the patient retain the right to deny the officers knowing any further from their medical side at that point? Or with him being in custody, what does that do for us?
Yes, they still have the right, because even a prisoner has the right they don't really necessarily have that much control over their medical information as a person who's not in custody, but it's still their medical record.
So, in that same line, Chad, that's a great point. When we have a patient in the back of the truck that's in custody and we have an LPD officer riding with us in the back of that ambulance, we are performing medical care in the back of that truck that that officer is privy to.
Right,
How do you?
you don't, you just,
Okay.
Document that he's there.
that's right.
All right.
And that the patient's in custody. Don't leave out that part,
Correct.
because that's an important part. And part of our policy on prisoners is you have to have an officer there.
And remember, you're not disclosing in that point, you're just performing your job and it's being observed. Okay?
Similar question, going back to video cameras, as far as us being held liable for what's released, what's the difference between a cop with a body cam and a random guy in the corner with a cell phone camera? And we really can't control either one, but if a
No,
cop
we
is
can't.
recording it, we're gonna be held
Well,
liable.
the only difference you have is access, proximity. The police officer can get right up to the patient, to
Right.
the victim, where the spectators are not, generally are not going to be able to have that proximity to the patient. And so, if that's the real distinction there. So if the patient says, look, I don't want to discuss some of this stuff, like if you're asking the question, have you taken anything tonight? Have you had anything to drink tonight? And they're impaired, they may not want that police officer standing right there listening to hear that.
Right.
And so they may say, well,
And to record it.
yeah, so they may say, well, can you ask the police officer to step away? Again, that's what you do, you ask.
And, you know, you have to remember that, yes, if there is a cell phone video and it gets released, yeah, they could come, the patient can file a complaint and say that it was our duty to protect or whatever. We're going to fight that. As long as we can prove it's not your cell phone that was actually doing the filming, then, you know, we'll go to the mat for you, and we will fight them on all accounts. So, and generally we can prove that it wasn't your cell phone just because of the angle and stuff like that. And the OCR has been very reasonable. They're not like some organizations with the federal government that are just like, you screwed up, you're dead, you know, pay us this amount of money. They generally, because they understand, we see a lot of the baby mama drama and family drama, and, you know, people are mad at one another, so they're complaining, and we did it, we screwed up, and we actually have no evidence of that. And so they've been really good as far as that goes. It's like, we can explain to what happened, and yeah, and we'll even explain some of the family dynamics. Yes, this is our employee, and this part of the family hates this person over here, and they're trying to get them fired. We have no proof they did anything that they've been accused of. There's no audit trail, there's nothing. And they've generally accepted that, so. And if you do notice people filming, and you're not directly involved, you're kind of standing there, you have time, either get in their way, ask them to stop, and remind them that if it was your loved one or your family member, this is not the way you would want to find out that they were injured. I just remember many years ago when those two girls died in that Porsche crash, and their families found out. They were going their way to school, and they were hit by a semi. Everybody went by the crash, took pictures, and posted on Facebook, and that's how their parents found out they were killed. And, you know, we took pictures of the dead bodies and stuff. So I just always remind people, if that was you, that's not the way you'd want to find out.
You can have them removed by the police department at
Yes.
any point. That's impedance of EMS, which is a felony offense.
Yep. So, and I would make sure the officers know and ask them to stop. Any other questions? So if you guys think of anything, you can always email us. We won't answer you, but hey.
And y'all be fairly quiet over here on this side.
Yeah, were you
No
guys
worries, no
like all
worries,
the
right?
late because you got to sit in the bad section?
All right, any more questions? Thank you very much. Okay, so we're going to add to this and start a kind of a new process for us with documentation. And I know, guys, we've talked about documentation, and we've talked about it, and then we've talked about it, and then we had some more conversations about it. And by this time, everybody's tired of hearing about documentation. But documentation is a huge part of our job because, like she just said, if it didn't get documented, it didn't happen. And so we've got to be able to prove for continuum of care, for subpoenas, for lawyers, for billing purposes, for multiple different things, our documentation is absolutely crucial. And we've talked about the SOAP format, we've talked about things, but we've got to make some more adjustments. So here's some of the new things. Just like our progress with our care has changed, so does our report writing. So back in the olden days when we won't say a few people in the room that were here, I didn't say it. You're shaking your head. I did not name it. When we started talking about they did handwritten reports, you know, they very difficult to read sometimes for the continuum of care if the doctor did get that. The billing system was very minimal at that time, and there was it had to be completed typically prior to them leaving the hospital. They had very few ambulance calls, and so that made that possible. Then the revolution began, the computers came around, the digital computer writing systems came along, and the evolution of the medical record really started to get robust. They're starting to keep a lot more things. The EMS record got put into that. ICD started back then, and the billing process started expanding on a global level. And the reports could only be written, though, on desktop, because we didn't have the portable computers, and some of the other folks in the room, not from the old handwritten days, but the other folks in the room remember having to go back to the station. You may be there till 11 o'clock in the morning after you've ran calls all night, trying to get all your reports done because it had to be done there. And then as we continued, the SOAP format really started to take off, and so our long narrative started to kind of go away because all the information was in the report. The problem with this is we lost a lot of the information that's required for billing purposes and making an ease of continuum of care, because is a doctor at the end of the day going to sit there and go through each detail and go through 6 pages when they can read one thing at the end like they're used to doing and get all the information? The digital signature came along, faxing capabilities. As soon as you press complete, it goes straight into the medical record at the hospital. The tough notebooks allowed providers to be able to leave and to be able to continue writing their reports through the day. And even more ICD-10 codes began to form. So where are we at now and where are we headed? Well, as of right now, ICD-10 has about 80,000 plus codes. That's 80,000 plus things that our billing department has to sort through in order to find what's going on with this patient, to be very specific. Not only that, our physicians totally rely on our care. They rely on our judgment on 12 leads to go to the cath lab, trauma activations in order to, whether to call an OR team in at night, cath lab once again, stroke, whether they're going to be going straight to the cath lab and with the clot retrieval guide. So they're depending on us a lot more, so these reports have to be extremely accurate. It may be the simple thing is that we reported we had to run a VTAC and they've had the patient in the hospital for the last week. Patient hasn't done anything, but they can go back to our report and say, there it is, we saw it. And so now they can trust that intuition instead of just saying that that's what it had occurred. The good news is we have a lot of this information already in our reports. Y'all have done a great job with your SOAP format, getting it into the report, through the report, but we've lost it in that long narrative. And therefore, that affects the patient care on the end of the day because the doctors are not digging through the reports. The lawyers will dig through it because they need it. And it affects billing on a huge aspect because it's very difficult for them to ascertain the information they need in order to get the proper one of the 80,000 codes in order to do that. So one of the biggest things is the Center for Medicare and Medicaid has said that your EMS narrative is what they look at. That is where they ascertain all of their information. They don't go through all 9 pages of the report to sort through what is what. They get it all from the narrative. What do our narratives look like as of right now? Very short. Yeah, it's mainly loaded them on the cot, moved them to the hospital, offloaded, and patient care given to so-and-so nurse. And that's about all our narratives are. The good thing is we already have all that information in the report, so how do we get it into the narrative where it's usable to where a physician can go in and get that information immediately, billing can go in and get that information immediately, and as bad as I hate to say it, the lawyers can get it very immediately without doing so much digging. So this is a report that I created using the auto-generate, now, I use that word. We all went through auto-generation a couple of years ago and looked at it. It didn't help. And it didn't help because there wasn't enough information pulled from the report in order to make the narrative robust enough to answer all the questions that's being needed. That's being needed by the doctors, by the billing, by ICD-10, by all these standards that are happening. The good thing is I use the narrative, the auto-generation at the bottom right here, to generate it, and it keeps it in a standard format, and then with just a click of a few buttons and a little bit of typing, I had a full narrative again. Because guys, at the end of the day, how many calls are you running a shift? Some days, it's pretty rough. And if I've got to sit there and type a full narrative, that's what's needed of me, that's what's going to be required of me, I have to do it. But how can I do it and do it in a timely fashion and have a good standard report to where it's easy format to follow? So we've come up with a way we can do this. So option one is we can use the auto generation button at the bottom. We can go ahead and generate, but when we do that, this is the way it looks. A lot of times it says not documented. Well, if I did the cardiac monitor and the intervention, it's documented. The thing is, auto generation pops it up unless it is written in the comment section. It doesn't pull any of that information. I don't know how many conversations we've had with Zoll over how do we pull this information. They said you can't. It's a hard programmed thing that's in there, and so they cannot extract the information of saying 18 gauge IV to the left forearm with 500 cc bolus, unless I type that in the comment section. Right here is what I did, is it's just got oxygen, and it said not documented. I erased that and put 2 liters per minute nasal cannula due to suspected cardiac event. I can't stress enough, when we do an intervention, why did you do that intervention? Are you suspecting, rule out MI? Is it chest pain per protocol? Whatever it may be, we're going to have that information in there. When we did the auto generation before, we pushed auto generate, it said not documented. We sent it to billing and said, here's what I did. And they look at us and say, there's no information there. It says cardiac monitor not documented. That's no help to them. So we have to figure out a way to get all this information in. As you can see, the nitro here says not documented, but what it would say at the end of the day would be nitro, 0.4 milligrams sublingual with desired effect. Now, that can even be expounded more and say, with desired effect due to chest pain at a 4-on-10 scale. And so we need to know where we started and where we're ending here. Once again, the auto generation button, if it's not written in the comments, it didn't happen in the narrative. And so am I asking you to double document, I made that word up. Double document things? Yes, it seems that way. But all I'm doing is transferring that information that I've already got in the report into the positions where it needs to be for the narrative purpose. I can do that one of a couple of different ways. I can either, it's going to say, hey, I've got spinal precautions here. And then in my comments, neuro checks were appropriate pre and post C-collar. And then I'm going to say that the patient was secured to cot with 4-point restraint and leg straps. Now, does that tell them what size C-collar if I cleared it? No, it doesn't. I'd have to go in and document that. So that's one of those things that we're going to have to add. If no comments are made in the intervention, it will default to the no documentation, or not documented. The caregiver will simply have to back that up and add that information in of what occurred in that spot. Option 2 would be not use the auto generation, and you're going to have to write a full narrative. Now, for some of us older folks in the room, that may have been a thing because we were very used to shaking his head. I'm going to get you tomorrow. But that's one of those things that a lot of us old timers in the room were used to writing long narratives, and so it's very easy. We all had a standard format, and it just took time to get used to it. Now, reading fires reports, all of y'all's stuff is basically in a narrative, is it not? And so y'all's would be, on a billing side, would probably easier to bill than ours is with everything laid out in great detail. Because when I read their reports from time to time, everything's listed in their narrative, and that's what they use. And so we broke away from that several years ago when we went to the SOAP format of getting it all in the report. Now, I got to speak with several people across the SPIMS region of how do y'all do it? Billing is a huge big thing, unfortunately. Continuum of care is a huge big thing now because lots of physicians, lots of lawyers, lots of people at the hospital, the nurses, they're depending on your documentation to know what happened. Whether it start on y'all's side and move to the EMS report, that continuum of care goes straight through where they can see everything that's happened. So the other option was for you to basically start typing a narrative, and you've got to come up with your own format. The nice thing is about auto generation, it lays it out for me into a specific format. But we're going to stay with the SOAP. That's what's approved, is using the SOAP format. So what is SOAP again? We've been through SOAP a few times. And we're going to go through each one of these. Subjective is the patient's story. What are you told? This is a description of the patient. This is their chief complaint, their history of events, what led up to what, why did they call EMS, who called EMS, why did they call EMS, why did they call the fire department? Well, my house was on fire and then I started having chest pain. Is the fire part of this relevant? You bet, because that's a stressor causing the chest pain versus I'm sitting there watching the football game getting stressed out over football. All of this continuum of care is important to fall back on what happened to that patient. What caused this chain of events of why they're calling 911. Pertinent past medical history. So if I had a gallbladder taken out 22 years ago and I've got a broke leg today, is that gallbladder important? No, it's not today. Now, is it an important part of their medical history? You bet. But it's not important for what's going on today. Versus if the patient was just released from a cabbage 2 weeks ago and now they're having chest pain, that would be very pertinent medical information. And any current medications and allergies they may have. So the objective portion, this is where I come in. This is the caregiver story. What did I see? Walked in to find patient sitting in a tripod position with respiratory distress. Patient was noted to be diaphoretic at that time and complains of chest pain continued without relief from sitting for 30 minutes. Those would be very important things that I saw versus if I'm in somebody's house and they have an LVAD and their percutaneous cord is horribly infected and I notice that there's six piles of trash and there's dog poop in the floor and there's dog urine and the house smells bad. Does that contribute to that sepsis here? You bet it does. And those are important things that I need to put in my report because those are what the caregivers saw. Those are what you guys saw when you first came in of noting that they're being treated for a burn. Well, yeah, they walked in the house and when I arrived on scene, the guy was walking out of the house, flames all over the place. We doused him down, got it off, and then turned over to care here. Is their report important at that point? You bet it is. Because it tells me exactly, he was on fire when he came out that door versus when I got there, no, he was put out, he was just laying there. And so I've got to add those continuum of care in order for us to provide that great care for that patient long term. Then we move into our assessment. This is the impression that I give. This is my field diagnosis. Now, is every chest pain an MI? I would venture to say of all the chest pain calls we run, 20% of them are active MIs that we are calling a heart attack. But I can use the term rule out MI. I can use the term, suspecting chest pain, rule out MI, secondary to the patient complaining of chest pain on a 10 to 10 scale. With diaphoresis noted, patient short of breath, denies any nausea, vomiting, and pain radiating to the right shoulder. That would be very important information here because that's my impression. I'm describing what I'm thinking it is, rule out MI, and my supportive evidence of what is causing me to think that. Then I have the plan. What did I do for the patient? One of the biggest things we've got to have is where did we start, especially with pain? Pain documentation. Where did I start with my pain here? Because did my therapies help? Did my therapies not help? That's a continuum of care issue. If I give Alan an aspirin and one nitro and it relieves his chest pain versus one aspirin, 3 nitro, some morphine or some fentanyl, and then back to more nitro, what does that tell you about his chest pain? It's a lot more extensive. My injury pattern may be big. I may have been able to stop that. I may not have been able to stop the injury pattern. I don't know. Serial 12 leads. Where did I start? Where am I ending? My therapy has to document that. Not only what I did, how I did it, but what improvements did I have in that process or worsening in that process? Patient placed on CPAP, moved to the truck immediately. Severe respiratory distress, patient showing fatigue, patient unable to speak in words at this time, patient unresponsive, airway was taken. That justifies that process. Is that your fault that that patient stopped breathing? No. Were you behind the 8 ball when you walked in the door on that? Probably so. It's not your fault, but I've got to show the continuum of care of my treatment didn't work, so I had to do this. Or my treatment did work and I was able to prevent that intubation. Those important things that come along. Then also in part of the narrative portion of SOAP format, this is technically not in the SOAP, but we start talking about our closing statements. This is not traditionally part of that SOAP format, but it provides us a way of knowing patient was full body lift to the cot. Why? Due to chest pain and trying to decrease stress on heart. Patient was full body lift to the cot, or patient 2-person assisted to the cot due to weakness. Those are things that help billing. Those are things that help that doctor of knowing, oh, he was even too weak for them to stand up, so they had to help him. That tells me where was my heart function at that point. It leads up to what's going on. In my transport, was my patient transported emergently or non-emergently? When I arrived at the hospital, I went to room 6, and patient was full body lift to cot with report and transfer of patient care given over to so-and-so RN. These are important factors because it tells me how I got from point A to point B. This is something that physicians look at, lawyers look at. So you're telling me that you walked him to the cot and he was having chest pain and he died? You're telling me you walked him over there? Really? And so that's what these guys are looking for. That's what billing's looking for, to justify our ride to the hospital. What happened? How did I get them there? And so these details become hugely important for us, and it's something that we've gotten horribly laxed at over the years, and something that's got to be fixed. So we don't want to leave someone who's reading the report thinking. Tell them the story. Describe the story exactly what you did. I would venture to say that if we could find out a way for you to talk like a doctor does and dictate, your reports will be absolutely fabulous because you can talk a lot faster than you can type. I know I can. Now I have trouble talking because I'm real shy, but part of that process is I've got to be able to translate from my voice into that typing. That's the only way that the continuum of care can happen. That's the only way you can build those reports. That's the only way you can defend yourself to a lawyer. Guys, it's sometimes hard to remember what I had for breakfast yesterday morning, much less what happened on that call in 2 years when I got to go to court for it. I've got to have the details of exactly what's going on. Who saw it? Who called 911? That's an important thing. When did it happen? Where did it occur? Why? Well, I was having chest pain because I just smoked methamphetamines. Is that an important spot? You bet. That's a totally different treatment plan for the doctor at the end of the day than it is for chest pain because you got coronary artery disease and 100% blockage in all your on your LAD and RCA. So I've got to be able to justify that. My pain scale. Where did I start? But guys, where did I end? I gave them fentanyl. We were at 10 on 10 and now we're at 8 on 10. So why didn't you treat them some more? Or you took all their pain away. Great, so you fixed it. Tell the story about it. Describe what you were told. Describe what you found. Do your findings support what you're told? That's a huge big thing. You know, patients complaining of left ankle pain. I don't know how many times I look at a report and it's got left ankle pain and there's no assessment of the ankle. So what'd you find? Well, I don't know. I didn't see it. So that's a hard thing to be able to justify what they're complaining of versus what I found. Now, from a BLS side, that's usually the harder report to bill out. Because I'm not doing all these skills, I'm not doing all these things, and I do a poor job documenting traditionally with 29-1s and 30-1s because it's not as big of a report. You're thinking, oh man, this is going to be easy. I'm done. And I don't read it. Versus if I assess that ankle and I say, patient complained of left ankle pain, no swelling, no deformity noted, but patient still continues pain. Continues to complain of pain there. Just because I don't see something, I don't find something, how many times have you seen a fracture on an x-ray that you were thinking, that ain't broke, but it's broke? So it's important for you to tell their findings, and does it complement your findings? Or do your findings complement their complaint? That's one of the things we need to stress. Does it hurt once you get the pain scale? Did it get better or worse? Where is the pain or lack of pain? You know, patients complaining of hip pain, but ankles noted to be grossly deformed. That's an important thing. We need to get that in the report. Is it the right, the left, the upper, the back, the medial, the posterior? Those things become important. And so many times we see a report, patient ejected from car, was walking around the scene on arrival, patient complains of severe right shoulder pain, and I see no assessment. What did you find? That's what they're telling you, but what was your findings? Because when they have that dislocated shoulder, they tore something, and the lawyer comes and they're going to say, what'd you do? You didn't even tell me what you saw. Can we defend that? Absolutely not. Because in 2 years, you're not going to remember. I promise. So we've got to have that in place in that report. Very detailed. Was there deformity or lack thereof? Swelling, rotation. Which direction was it rotating? State the facts. Don't allow them to assume. Because a lawyer is going to assume you didn't. He's going to assume your care is bad. Medicare is going to assume you didn't, so they don't pay. They're going to assume that physician's going to say, "What? I didn't see, you didn't document anything." But you're not doing really good care because that patient now has a horrible dislocation that you didn't even assess. Oh, I assessed it. Well, where's it at in the report? It's not. And so we've got to be able to defend those processes. So this is a BLS example. I used the auto generation. Then I went in and just added the notes, added the things that were important for that. The things like pertinent negatives and pertinent positives. Patients complaining of chest pain, but denies any diaphoresis or nausea and vomiting. Those are pertinent negatives that need to be added. Must document what has been done for the patient as part of the medical necessity. Patient placed on the cot and secured ×4 with the deal. How did I get them to the cot? That could justify the whole call right there of how I got them to the cot. Whether I had to assist them. Even if the physical signs and symptoms you don't find, but the patient still complains. Patient noted patient complained of left ankle pain. No deformity found. No swelling noted. No rotation noted. Those are important pertinent negatives. On the ALS side, ALS is going to typically be a little easier to take care of and bill and for a doctor to follow because we're doing a lot of things. When I walk in, I want to give a very detailed report. Hey, we gave him 16 epinephrine, we gave him 450 amiodarone, we tried some lidocaine, we did this and we did that. We'll typically give a lot better report. These doctors are going to be depending on this at the end of the day. Once again, with a few clicks of a button, I was able to follow the format, and as you can see, it states in here, it defines the medical history. It defines the caregiver's impression. It defines what I found and my assessment. And then it talks about my treatment plan. And then at the bottom, I just added in, we transported him emergently to University Medical Center. That's another thing. Guys, we got to spell this out. If we send this to an insurance company or some doctor's looking at it and it says UMC, they're going to go, what's UMC? University Medical Center, Covenant Medical Center, Grace Hospital, whatever it may be. We have to be very detailed with this. The patient was full body lift by sheet to the ED bed. Report and transfer of patient care was given to Kim RN. Those become very important things for us to share with that process.
Got it all covered?
I think so. I think it's in the details. It's all in the details. Don't you as a medic make an assumption. Don't you make an assumption. And I know a lot of you use your spell check, but make sure that your spell check is right. Make sure you're picking the right word. I had one just this week that I sent to Alan and Tom. The patient was sore, S-O-A-R, throughout the entire report. The entire report, and I bet it was in there 7, 8 times. Medicare won't pay him.
And the doctor's gonna look at you like, where are you soaring to? Okay, we get that, yes.
Quick question. Whether it be medical or trauma, we do still need to use that body survey, right?
We do, that's an important thing. Now, one of the biggest things is if, patient complains of abdominal pain, secondary to eating the 72-ounce steak and, Amarillo, and they drove home and they got abdominal pain, I need an assessment of that abdomen for medical purposes. I need an assessment of that. Then on the way home, they got hit by a car and they're puking everywhere, but they still complain of abdominal pain. That's important. I've got to have that assessment in place. That's a good point. So I've got to be able to back my finding. They complain of it, you need an assessment of it every time. Now, do you need a complete full body on every assessment? Probably not. But if they complain of something there, it needs to be documented. It has to be documented of what you found. You've got to support their findings or disclaim their findings. Pertinent negatives and pertinent positives. Tom, do you have anything to add?
No, I think that's pretty good. They do understand, they're doctors and nurses that are evaluating these things, so they understand what a Glasgow Coma Scale is and a Cincinnati Burn Scale and things like that. So you can use those terms and those rating structures, but you gotta remember, these are people who are primarily paid not to pay our claims the first time through. And so we've got to be very clear on what we found and why they need to be in an ambulance. Because the first thing they're looking for is, could they have gone by other means? For example, if you find them sitting in a wheelchair, well, they could have gone by a wheelchair van. If you walk them to a cot, well, they could have gone by Uber or taxi cab or by private vehicle. You've got to really lay out why they need to be in an ambulance. Now, not every patient is going to fit that criteria, and so be truthful, say what you found. We're not going to get paid on everything, and that's okay, but do your best to document what constituted the need for them to be in an ambulance.
So starting immediately as you leave and you go on duty Wednesday. So it's Monday, right? Yeah, Tuesday, Wednesday. So this group will be coming on Wednesday for the most part. Some leftovers from today that will be on tomorrow. You can start this process immediately. Start using your auto-generations. Your narratives are going to start we're going to start grading those. We're going to start looking at that process. We've got to add that in. I recommend personally you use the auto-generation and then go back and fill in what you need to fill in. That way it keeps it in a standard format and you don't have to think, well, what's next? It makes it an easy process. And so, guys, like I said, a few clicks, literally, it took me about 5 minutes to add all that stuff. As you get used to that process, and guys, you got to think about another thing. A lawyer's going to pull their report and they already use a narrative. You want yours to match that. You want yours to be able to complement, hey, they said that the guy had a deformity to the ankle. Well, you found deformity in the ankle. Versus if you said patient complained of ankle pain and I didn't have an assessment in there, but they did, man, that's sure, you got to weigh that. Well, who's, which way do we go here? And so we've got to get that documentation in place. Not for all billing purposes, for a continuum of care, for legal purposes to protect yourself as providers.
Use it as a tool. If you get through with it and you look over your narrative and it says chest pain not documented, that should be a trigger. I forgot to put something in there. I need to go back and I need to fix this.
That's a good point.
Use it as a tool. That's what it is.
Any questions or comments? Yes. Sorry, go ahead.
Do you want us to use the auto-generate on injuries and informs also?
My preference is you use it all the time to stay into the, now, if you so choose to write your narrative, write a narrative. I'm just thinking from a legal purpose, it's going to help cover you. What's our number one thing we get subpoenaed for is refusals and no injuries. Probably more so than anything else. So I would use it, and that way you're in a habit. And so that's what we got to do today is break a few old habits, and I'm just as guilty as anybody is. But it gives you an opportunity to stay in the same format each time. That would be my opinion of that. That's what I will use when I'm writing reports. Yes, sir.
Just remember whenever you do this, on chief complaint, whatever you select for your chief complaint, whenever you hit auto generate, to get rid of that chest pain not documented. Down at the bottom where your box is, which you open up to write your comment about chest pain, just to the right of that is a little clock. If you will click on that clock and put 2 minutes, 2 hours, whatever the patient complains of, it will put in there chest pain for 2 hours, chest pain for 2 minutes. It puts it in there for you, and then that's one less step that you have to do.
Starts to answer your own questions.
There's a lot of tricks on this auto generate, I promise you, and I personally love it.
You'll get it down and it'll make it very easy to be routine, just like the other reports. Any questions? Yes,
Not
sir.
a question, just a comment about using auto-generate. If you do something on your monitor and then upload it, your timeline on your interventions are gonna be out of whack. They're gonna be out of sync. So we need to either get with Zoll and try to fix that, or it's gonna take us 20 minutes to get those times.
We have had that conversation already, and it's a hard programming thing. I don't know what they're gonna do on it. We had this conversation for 2 hours the other day with support. I was literally licking the computer glass by the time I was done talking to them. Very
But
frustrating.
the way it auto-generates though, it's gonna be out of line. Now you have got a 12 lead before you did a set of vitals, or you've got, down at the bottom, you finally have an IV started.
Right.
When you did it way up here.
Right, and that's just when you upload. That's only on your
It's on
upload.
your, well, or the order that you add your interventions in.
Right.
Because it will
Well,
put
it's gonna-
them in
now-
that order.
Another thing, it'll only drop one vital sign that it generates. So auto generation kicks out one vital sign for you. What's the standard on that?
It's your protocol, whatever you want to do.
State
Okay. State requires two. Now the state's still getting, let me rephrase something real quick, it's a good point. In your interventions, when you put 12, all those little boxes at the bottom that we still have to click, 18 gauge, forearm, left, 500 cc bolus, NS. That's where all of the auto population comes for the state side of everything. That's why we still have to document everything in the interventions and then move to the report for continuum of care.
So with those interventions, we need to be documented in the comments, 18 gauge.
You can, but you're still gonna have to click the boxes too.
Right.
That's the bad thing, because that's where the state generates 2 sets of vitals. What was done, and that's what covers you. Started by, and this is another thing, LFR medic, that's what ours says. The name needs to be in there, what skill was done. Because it's gonna go, well, who was it? Versus, so it's gotta be documented of a name of who does that skill. Okay? Any other questions? Very good questions, yes.
You said it pulls up one set of vital signs only, first or last set, say on a BLS report?
It is the first set.
First set.
First set, yeah. And that would cover enough for, I'm assuming, for what y'all need.
Well, unless there's a big change.
Yeah.
To prove that what you did fixed the problem.
Yeah. And that could be,
Lowered the blood pressure,
Right.
lowering your blood pressure or blood pressure.
so just things that are, found things, once again, your impression of this is what fixed or did not fix.
Same with SPO2, make sure you put that in there, that's a big one.
Yeah, improvements. I see a lot of times people just, it'll click up and it'll say 88%, but patients now, alert and oriented, I doubt if they were disoriented at 88%, I doubt they're gonna be oriented now at 88. So you just kind of wait it. Any other questions?
Yeah, if somebody chooses not to do the auto-generate and they just can write a full narrative, you still want all that information in the
We do.
subjective. in the
SOAP format, yeah. Follow your SOAP format if that's what you choose to do.
But even in the tabs under subjective, you still want all that information.
All that information has to be in there because that's where the state populates their stuff. Any other questions?
Chad, I think what's important to know is when you check the box, that's gathering data. And we analyze data, and the state analyzes data. But for reimbursement or for the continuum of medical care, nobody really looks at that. So what they look at is the narrative and what you wrote. So you've got two different things going on. You've got the gathering of data, which is the check blocks, and then you've got the continuum of care and the history and stuff, which is in your narrative. And sometimes the two don't really mesh because they're for different purposes.
Guys, immediately this starts, that you've been educated, You're welcome to go out and practice tonight if you want on the report. Y'all have a great night. Be safe.